Injury Prevention Network, and the Safe States Alliance. We thank you for joining us. During today's webinar, you will hear the second part of the foundational information for the Injury Policy Opportunities Project, which is designed to give you resources for working on policy and to hear about some successful policies at the state level in Ohio and Kentucky. Through this series, participants will learn effective strategies for preventing and reducing opioid overdoses. As a reminder, to ensure a successful webinar experience for everyone, please be sure to mute your line. Close out of unneeded programs for the duration of the presentation to ensure you have a good connection. Should you have technical issues during the presentation, I will be available to assist. Please just send a message or use the raise hand feature in your GoToWebinar taskbar. And finally, please note that the presentation is being recorded and will be made available following the webinar. I will now introduce our moderator for this webinar, Jennifer Woody, the coordinator of the Southeastern and Southwestern Injury Prevention Network.
Good afternoon, everyone. Welcome to the webinar, the second in a series of 3 presentations in the Injury Policies Opportunity Project, or IPOP. The focus of the IPOP is prescription drug overdose, and it's designed to give you skills to identify, educate, and evaluate policies that can help prevent overdose deaths. These first 2 webinars have been open to the public. The final installment in the series is a 3rd webinar and a 3-day skill building workshop, which will only be available to a limited number of participants. We are going to learn a bit more about going further with this within the IPOP project from our faculty Carolyn Crump and Jim Emery. They will briefly describe the topics that will be taught. Both of them are with the UNC Gilling School of Global Public Health and work in the Department of Health Behavior, where Carolyn is a research associate professor and Jim is a research associate. Their work focuses on helping communities and organizations enhance their strategies and methods for changing policies, systems, and environments to create healthier living opportunities. So Carolyn and Jim, I will turn it over to you now.
Great, thank you, Jennifer. My name is Carolyn Crump, and Jim Emery is with me. We are happy to take a couple of minutes to orient you to the going further part of the IPOP Academy. Jim and I are part of a service-oriented team where we've been working with local, state, and national organizations across the country for about 20 years at this point. We've emphasized and are primarily focused probably in the last 15 years on increasing the ability of public health professionals and their nonprofit partners to be more successful in changing policies, systems, and the environment. Our content focus has varied across a number of areas: injury prevention, physical activity promotion, occupational safety, prescription drug overdose, children with special health care needs, and there may be a few other things thrown in there. The important part, of course, is this process of changing policy systems and the environment. Next slide, Julie. So the going further part, we wanted to make it a practical application that you could really apply the process to a current problem in your community or your state. And while there's no prior experience in policies or systems work required, our intention in January is to introduce you to some tools that you could use and then come to the workshop kind of really prepared to move your work forward. We have, because it's a limited number of people that can participate in the in-person portion, we have set up a registration that's required, and you'll see that the applications are due December 9th, although there is an incentive for early bird applications that get their application in by November 30th, and you can see the prices in the green box there. So it would be a $100 saving if you can get your application in by November 30th. Next slide, Julie. So the webinar we're going to focus on, stakeholders are so important in doing the work to change policies, systems, or environments. And so we wanted to share with you a couple of tools that we have developed for being able to document stakeholder perceptions on a problem, and in general, what are their values, what are their perspectives, what are their ideas for solution. And the idea would be to orient you to these tools in January, and then you would be collecting some of this information, working potentially with your team, or if you were coming as an individual, you could also be collecting some of this just as an individual, and then bringing that information with you to the workshop. Next slide, Julie.
So this is Jim Emery, and I'm going to tell you a little bit about the IPOP Academy Workshop, which is in April. It's going to be held in Chapel Hill, North Carolina, near the university. It's going to last 3 days. It is a skills-building workshop, and we encourage the teams or individuals to come to the workshop with the tools they got from the webinar and they might have applied in their local community, and bring those data with them to the workshop. During the workshop, you can see in the enumerated items, that's the rough outline of an agenda for the 3 days. We're going to cover things like building a simple systems map of the problem that you want to focus on, search for and organize relevant data and evidence that can inform the solutions, prioritizing those solutions, what is most impactful, what is politically feasible. Number 4, critically reviewing policy language. This is going to be looking at actual policy language and learning how to read it, how to look for what it means, look for the various sections, try to determine the quality of it, and looking for loopholes. Number 5, conducting a stakeholder power analysis to inform strategy development, trying to understand who is most powerful and what is their position on the issue and on the solutions you hope to push forward. And then 6, outlining a strategy to influence decision makers, making that strategy viable to those particular individuals and groups. And then 7, communicating that by framing key messages about the problem and the potential solutions. Next slide, Julie. The workshop is going to include a range of adult learning methods, such as individual reflection, skills building activities that could happen in partnerships, groups, or in your team that you might come with, training on the use of key tools, and then applying via a case study. Carolyn and I will be the trainers. We have experience in this in terms of having developed a large national training curriculum on policy change and systems change, which is marketed through various organizations. We specialize in adult learning methods, and you can see more about us on our website. And next slide, Julie. The registration process is going to be a short form that helps us understand who you are, why you want to attend, what participants you might be bringing with you, and what your issue is you think you might want to focus on, including some of the stakeholders that are important in that issue in your local community. That'll help us get a sense for what your team would be wanting to focus on during that time. We're going to be selecting from the applications because there is limited space, and this will allow us to formulate a group that's going to learn the most from one another during that session. So keep in mind that November 30th is the early bird deadline, December 9th is the final application deadline, and acceptance is going to be right around January 6th. And that's it for us. Thank you.
All right, thank you so much, Jim and Carolyn. That again, you see the link on the screen there, and we will post that in the chat box so that you are able to actually click on it. But you'll find all the info you need to register and the date, so in case you forget them. And further, just as a reminder, this webinar is being recorded and it will be posted for you all to review or to share with other stakeholders that aren't able to be on the call with you today. So we're going to go ahead and get started with our presentation and our great presenters. I'm going to introduce folks as they are presenting. And first up, we have Corey Davis, who is a senior attorney at the National Health Law Program and deputy director with the Network for Public Health Law. His work focuses on improving public health through law and policy, and he is a recognized expert in law relating to overdose prevention. Corey received his BS from the Indiana University of Pennsylvania, his MSPH from the University of North Carolina at Chapel Hill, and his JD from Temple University. So with that, I'll turn it over to Corey.
All right, thank you. Thank you. I would say I prepared a 30-minute presentation. I've only got 20 minutes, so I'm going to go through it relatively quickly. So here's where we're going. I'm going to start out talking a little bit about pain, and then talk a little bit about overdose, and then kind of move on to the meat, which is law, regulation, and policy, and what they can do to help and what they can do to hinder. I'm going to focus on a couple of the ones that have seen the widest adoption throughout the country, and those are prescription drug monitoring programs and access to naloxone. But I'm also going to talk a little bit about some sort of interesting and innovative things that some states and municipalities are doing that kind of move beyond those big picture innovations. So I really think that any discussion of the overdose crisis needs to start with pain. Pain is a significant public health problem. It's in fact the most common cause of disability in the United States. An enormous number of Americans live with chronic pain. You can see here 25% of Americans report that they had back pain that lasted at least a day in the past 3 months. And rates for other types of chronic pain are nearly that high. There's also this sort of, I'll say, interesting fact that people of color, African Americans and Hispanics, are historically undertreated for pain, and I will use undertreated possibly in quotes. They are less likely to receive, on average, opioid therapy for pain, which in some surveys results in people of color reporting higher rates of pain. Now it's a little difficult to suss out that exact correlation, and of course, as I say here, lower income Americans are more likely to have the type of jobs where they're likely to be injured, particularly those sort of repetitive stress injuries, those lower back injuries. And they're less likely to be insured and less likely to have high quality insurance. So where I'm going with all of this is that incidence and prevalence of pain are not equally distributed throughout race, ethnicity, and socioeconomic status. Why is that important? Well, it's important because, as the World Health Organization tells us, freedom from pain is a right, and access to pain therapy should be seen as a measure of respect for this right. No one should live in preventable, treatable pain. That brings us to opioids. Now, of course, opioids can be beneficial for certain kinds of pain, particularly post-surgical pain and palliative care, end-of-life care, severe cancer pain, severe HIV pain. But as everyone on this call knows, they can also have significant negative side effects. And we see, I've got a slide here in a minute, but increasing opioid prescriptions have resulted in increased opioid-related harms. I think it's also important to note that even when prescribed according to practice guidelines and when used as directed, opioids have, sometimes significant side effects ranging from opioid-induced constipation to lethargy. There's also a strong correlation between opioid use and depression and other mental health disorders. Now here's a slide. It's a little old and it's not formatted well because I stole it directly from CDC, but you can see the indications for which opioids were prescribed in 2010. The important thing to see here is that you've got a lot of opioids being prescribed for indications for which there is no evidence of efficacy, or in fact, some of these have pretty good evidence that the opioids are not efficacious at all, at least at the population level. Osteoarthritis, lower back pain, neuropathic pain. For most patients in most situations, opioids not only do the risks outweigh the benefits, but there's very likely to be little clinical benefit whatsoever. So it's not a trade-off between pain relief and safety. As I said, there is very little evidence that opioids are effective for many of the things, many of the indications for which they're prescribed. Opioids simply do not provide better relief than non-opioid therapy for most chronic pain. I am not saying that opioids should not be prescribed. I'm not saying that if you are a patient or have a patient for whom opioids appear to be working, if everyone understands the risks and the benefits, that they should not be prescribed. I'm not a clinician, but this is what the evidence tells us. Here you can see, this is one of those pictures that's worth 1,000 words in my mind. You can see that the increases in prescription painkiller sales track extremely closely with increases in overdose deaths. I think we all know this, but I do think that it's worthwhile to take a look at this chart. I'm not going to get into this too deeply, but I will say that there have been a number of criminal and civil complaints and settlements with various pharmaceutical manufacturers. This is back from a decade ago now. Purdue Pharma, the corporation and 3 executives were pled guilty and paid $500 million in fines related to illegal marketing of OxyContin. Of course, that pales in relation to the amount of revenue that OxyContin generates for that company. And they're not the only ones. Here's just another way of looking at that. You can see, unfortunately, when we extend this out to 2014, that opioid analgesic line goes up a little bit. But I want you to see this dramatic increase from 2010 to 2013, and of course that goes up even further to 2014. There's, again, the connection there is perhaps not as direct as some people like to pretend, but it is clear, I think, to most experts. It's certainly clear to me that there is a connection between the increased prescription use and initiation of prescription opioids and the dramatic increase in heroin-related deaths. Again, there's a lot of other things going on there. But I think there's clearly a connection. Now, I don't want to get into this too deeply either, but there's also other stuff going on, right? So this is from the pretty famous K-Steaton paper that came out in the proceedings of the National Academy of Sciences a few months ago. And what we want to see is that mortality is going down for middle-aged people everywhere except the United States. It's unheard of in a developed country for this to happen. And on the right-hand side, you can see what's driving it. And basically, it's drug overdose, it's suicide, and it's alcoholism. So there is clearly something else going on here. It's not just overprescription of opioids. There is something going on among middle-aged people, particularly middle-aged white people in the United States, that is causing people to self-medicate. And there's a whole, webinar to be done on this, but I do think it's important to keep that in mind. And here you see this divergence among race and ethnicity. This is overdose death through 2011, but these trends have not changed. And you can see that the increase has been much more pronounced among non-Hispanic whites. What's driving that? Not clear. Part of it is probably that protective effect. I'm using air quotes, but I think that that's correct, of less prescribing of opioid analgesics to people of color. And again, that's not a normal judgment. That's I think a pretty good hypothesis. This is also not to say that we wouldn't care about this if if it wasn't primarily affecting white people. I think myself and a lot of other people have been worried about this for a very long time. But that is the fact. Now, okay, does law matter? Well, I'm a lawyer, so I, for professional purposes, like to think that the law matters. The research on this is actually a bit mixed. Here's a paper from a bunch of folks in the federal government. What we know and don't know about the impact of state policy and system-level interventions on prescription drug overdose. And this paper looks through a bunch of laws and policies and basically says, we don't know very much. We don't have enough data. The laws are relatively new. The effects are relatively modest. It's not clear what's going on. This is from the New England Journal of Medicine just a couple of weeks ago. It looked at a number of laws that had been passed and implemented in the states to try to prevent prescription opioid-related harm. Looked at a particular population of disabled adults, disabled adult Medicare beneficiaries, and found essentially no effect. I don't personally believe that there is no effect, and we can talk about that. It's a whole other webinar again. But let's say that stuff is out there, and I guess the point here would be, we don't, laws and regulations are important. They're not a magic bullets. There are a huge number of things that go into changing attitudes, behavior, beliefs, and outcomes. Laws, I think, are an important part of that, but they're not all of it. So here, I kind of trying to show that a little bit. This is how the policy intervention continuum. And, I think about, you start, in my mind, you kind of start at someone who is an active overdose. Imagine this, this arrow. Way on the right side, you have someone who is actively overdosing. And you kind of move back, right? So what are the interventions that we can have, effective interventions or interventions with at least some plausibility behind them to help at that point, and then move back, right? Because our ultimate goal is to get people, before they start moving down this, this risk continuum at all, right? So all the way on the left side, we want to reduce improper prescribing because we know that this is a largely iatrogenic epidemic. We know that a lot of people have their first interaction with opioids from a prescription, either something that was prescribed to them or something that was prescribed to someone else. And so I'm not going to read through all of these because we don't have a huge amount of time. And this is not an exhaustive list. These are just examples, right? Some ways to reduce improper prescribings, give better education to prescribers. Prescribers consistently say that they don't feel comfortable, they don't have a good grasp of best practices, they don't know how to prescribe well, they don't know how to have difficult conversations with patients, they don't know what non-opioid interventions are available. Insurance incentives are huge. As long as it's easier to write a prescription for OxyContin than to try to get a patient, for example, into physical therapy or acupuncture or refer them to a mental health professional, there's going to be incentives, conscious and unconscious, for providers to do that. Okay, so I'm not going to go through these, but in the middle, we've got people who are at that point where they are misusing or abusing opioids, or they are a person with a disease of addiction. There are a lot of things we could do to improve access to care there. And like I said, I'm not going to go through them. And then on the far right side, when you have someone who is actively overdosing, the big thing there really is increased access to naloxone, both in the community. We need to get naloxone into the hands of people who are already on the scene. That means people who use drugs. That means the friends and family member of people who use drugs. We also want to encourage those people to call the professional first responders, the people who come when you call 911. And that means you can't arrest people. You can't throw them in jail for doing that. All right, so very briefly, I want to go through prescription monitoring programs. I'm not going to, you all know what these things are. You all know that every state except one now has PDMP legislation. You can see the progression over time, big increase in the last decade, really just in the last 5 or 6 years. All right, I'm not going to, talk to you about PDMPs, but I do want to, kind of talk through the PDMP logic model. And in my mind, this is kind of how PDMPs are talked about, at least historically. It's getting a little better. Number one, we create the PDMP. And what's a PDMP? It's a database. It's just a database. And then, step 3, overdose deaths go down. Okay. We need to do a lot more talking about what goes into step 2. I think that states are doing a much better job of this than they used to, but I think that this is still really glossed over. There's just this idea, like we'll create this database, we'll get doctors to check it, and then our problem's going to be solved. All of the data that we have examining the effectiveness of PDMPs suggests that that's not true, or to the extent that that's true, the effect is much smaller than we might hope. So I think that we need to, really think more about number two. What are the goals of PDMPs? What are we really trying to accomplish here? What is the logic model? What is the methodology behind how they're going to reduce overdose? If that is even their goal, and there is some research out there, some of which I've been a part of, when you look at the enabling legislation for PDMPs and you look at the PDMP websites, there's not much there about reducing overdose. It's all about reducing diversion. It's about catching doctor shoppers and that kind of thing. That's fine, but those are not public health outcomes. Okay, if we want, to improve health outcomes, we need to be very clear that that's what we want to do. We need to think backwards from that. How do we do that? And again, a whole other webinar just on this. But I do want to kind of plant that seed for you folks. So PDMP wrap-up. Evidence of efficacy is mixed. I do think that the emerging research evidence says that, these modern PDMPs, you're capturing all of the data, you're requiring clinicians to access it, is probably having a modest effect. Unfortunately, the data we have shows that in most states it is, very modest. And it's really focused on outliers, particularly outlying patients, to a lesser extent outlying providers. And that says to me that that idea that we'll have this database and clinicians will check it and that will solve our problems, it never had much evidence behind it, and honestly didn't have much thought behind it. It's not enough. Even from the clinician standpoint, that physician needs to know what to do with those data, needs to be empowered to do it, needs to be incentivized to do it. If I'm a physician and I check the PDMP and I see, oh, this is a doctor shopper, and I throw that person the door, I show that person the door, I have in all likelihood not done anything to benefit that patient. I might have made their life worse. Need to reframe them as overdose prevention tools. In my mind, that means letting state health departments see patients' specific data from the PDMP so you can reach out to those patients with public health interventions, which, by the way, we know work. And we need evidence-based treatment, an easy way to link people to it. No state that I know of is using PDMP data to proactively reach out to people who look like they may have poorly treated pain and are in need of a pain consult or addiction-related care. To me, that's a no-brainer, and again, goes back to this idea that I don't think we've really thought out how to use PDMPs as tools to improve public health and patient health. All right, same thing with naloxone access. I'm not going to go through this in great depth. You all know what naloxone is. You all know the majority of you are now in states that have liberalized naloxone laws. They vary enough between states that it's difficult to say a huge amount about them in specificity. I do think that this, what I call here the legal environment overview, is important to know. It's important for clinicians to know that they could always prescribe naloxone to their own patient. They can still do that. There's absolutely nothing wrong with that. There is no increased liability with prescribing naloxone as indicated and as permitted by state law. And most of the state naloxone access laws provide additional liability protection for prescribers, for dispensers, in many states also to people who administer naloxone. We have some information about this on our website, networkforphl.org. You can email me. I'm happy to talk to you about it. But naloxone is not over the counter. It is not available without a prescription in any state, and so that is still a barrier. In many places where governmental agencies are not purchasing it, or you don't have a big grant to give it out, there's still these big access barriers. Like I said, nearly every state has modified law to increase access to the medication. I'm not going to go through these. The big thing I would say here is that the thing that I think more states need to do is to ensure that the medication can be stored and distributed by lay people, by your nonprofit organizations, your homeless shelters, your public health outreach workers, all folks who are not otherwise authorized to distribute naloxone really need to be able to do it. And some states have done that, but not all of them. Same thing, overdose Good Samaritan laws. These are laws that, again, there's variation between the states, but say something to the effect that if you are witnessing an overdose and you call 911 to report it, you're not going to face criminal action for minor drug-related crimes. I think that these laws need to be strengthened. I think that states need to do a much better job of letting people know that they exist. I think that prosecutors need to follow the idea behind these laws and not try to, strictly follow the letter. The idea here is that we're more interested in saving somebody's life than we are in arresting someone for a low-level drug crime. And we need to make sure that the laws are actually doing that in practice. Here you can just see the increase in passage of these laws over time. You can see a really, really rapid adoption of these laws, which is really quite extraordinary for interventions that don't have, there's no big interest group behind these. There's no Chamber of Commerce. There's no ALEC that was pushing these things. It was just states seeing what other states were doing and advocates in the states who are pushing these things. We're starting to have some pretty good evaluations of naloxone distribution programs. They work. We lay people and people who use drugs can very quickly understand what naloxone does, how to recognize overdose, how to deploy naloxone. And the emerging evidence is that increased access to naloxone in the community does, in fact, reduce overdose deaths. It is cost effective. It would be extraordinary if we found that either of those things weren't true, because we know that naloxone reliably reverses opioid overdose in most cases. So I kind of also want to talk quickly about access to care, right? So way back on the left-hand side and going back to the Case-Deaton paper to some extent, we have a big problem where a lot of people in this country cannot access evidence-based care. As I said, people of color are more likely to be uninsured. Underinsured, so are people in lower socioeconomic classes, just less likely to have access to evidence-based care. Not only substance use disorder treatment and mental health treatment care, but just, high-quality pain care, access to high-quality providers. The Affordable Care Act was a big step forward in this. Reduce the uninsured population by, it depends on who you ask and how you count. This is 16.5 million people. Some estimates are closer to 20. But there's a very big decrease in the number of people who are uninsured and are underinsured. And those increases in access to care were much higher for people who traditionally or historically had less access to care, so people of color, women. And like I said, I'm not going to go through these in much detail, but the Affordable Care Act also expanded the reach of something called the Mental Health Parity and Addiction Equity Act, which should expand access to mental health and substance use disorder treatment. Unfortunately, it seems that a lot of states and a lot of insurers are not doing a good job of implementing those requirements, but hopefully that is improving. Medicaid expansion is a huge, huge thing. The best way to increase access to care for low-income people and people of color is to expand the Medicaid program. 32 states have done that, and that's all I will say about that. I do want to really quickly talk about some other things that states are doing beyond those, the PDMPs and naloxone laws. Like I said, one of the things that I think is interesting here is just the low level of information that physicians and other prescribers have regarding opioid therapy and pain treatment. Dr. Nora Volkow is fond of saying that veterinarians get much greater levels and amounts of training in pain treatment than do medical doctors. That should not be the case. You put that in conjunction with the fact that we have direct-to-patient advertising, we have direct-to-provider advertising. You've just got this a lot of people, a lot of providers being pushed to do things that may not benefit their patients. So I said here, it doesn't seem like the state medical boards, again, painting with a broad brush, you know, my email's at the end, so you can send me your hate mail, are doing a very good job of policing their providers. So states are starting to step in. I've got a couple examples of that here. So here are pain clinic laws. This map is from NAMSDL, the National Alliance for Model State Drug Laws. States are stepping in and saying, look, if you treat, you know, there's also variations among these, but say, you know, look, if you treat a certain amount of patients for pain, or you are running something that you're claiming is a pain clinic, you need to have some very basic things in place. For example, you need to have a medical director, and that medical director needs to be board certified in pain management. That's just one example. Really trying to regulate, regulate some of these pain clinics. States are also increasingly enacting prescribing limits. You know, something that I really, would not have imagined would have happened just 2 or 3 years ago. Most of these have been passed in the last 12 to 18 months. So these are states that have passed legislative limits on initial opioid prescribing, saying, again, most of them have some, some relief valves, but in general, saying, look, I know that you're a physician, you've been to medical school, and you've done your residency and your fellowship, and I don't care. I, as the legislature, am telling you, you cannot prescribe more than 7 days in in your first opioid prescription. Again, this is something that we very, very rarely see the legislatures, sort of regulating the practice of medicine to this extent. But it's happening more and more and more, and I think we're going to see much more of this if the state medical, if medical profession doesn't very quickly do a better job of improving practice on its own accord. So there's a bunch of other examples of this. A number of states have other limits that are a little fuzzier. Most states now have non-binding recommendations. A bunch of states are now requiring prescribers to at least check the PDMP, at least in some cases, requiring or recommends referral to a pain specialist. Another example is you've got now 8 municipalities who have implemented these take-back programs and making the dispenser pay for them. It started in Alameda County, California. A bunch of other counties in California, King County in Washington has also adopted one of these. The idea was recently upheld in the Ninth Circuit, so I expect to see these things expanding. We know that a number of other large counties are also looking at these programs. And I'd say, there's not much evidence of efficacy for these programs. I'm just offering it here as an example of something that the municipalities may be able to do. All right, near the end here, I just want to say, we've got, there's this countervailing pressure to sort of double down on what we've tried in the past, charging very low-level drug users or drug dealers with homicide or murder, for providing drugs that killed somebody. It has zero effect on overdose. It's like that stuff has never worked. It's never going to work. We should really be moving past that. On the other hand, we have a number of jurisdictions who are really kind of, like I said, really thinking through what are our goals here, how can we best accomplish those goals. And there are a couple of municipalities who are really, considering truly innovative things. Supervised consumption spaces, which have a really, really, really good evidence base behind them. Decriminalization of some drugs, better regulation of treatment providers so you don't have these sort of fly-by-night sober houses, which actually increase risk for people with the disease of addiction. Here's what happens when you adopt a criminal justice approach to overdose prevention. you don't reduce overdoses, you put a lot of people of color in jail. So here's the wrap up, and of course happy to take questions at the end. Untreated pain is a serious problem, but opioids are often not the appropriate solution. We know that, so we have a pretty good idea of some stuff that works. We need to be doing much more of that. We need to be building the evidence base. We need to be doing, conducting rigorous evaluations. We're also in the midst of an epidemic, right? So we really need to be moving forward with stuff that has, evidence behind it. There is no magic bullet, right? PDMPs are not the answer. Just naloxone access is not the answer. Everybody needs to work together. You guys all know this. I think this last point is worth emphasizing. We don't always know what works, but we know it doesn't work, and we need to stop doing it. Sounds obvious. I want to put it on big posters and send it out to everybody. So my actual conclusion, every system is perfectly designed to produce exactly the results it's producing. We don't like the results that we're getting from the current system. That means the system needs to change. If we don't change the system, we're not going to get different results. There's my email. I'm always happy to get emails. I do answer them, and I look forward to questions at the end.
All right, thank you so much, Corey. That was fantastic. As some folks have already done, we've got a few questions that have been submitted, and we are keeping track of them for you. So please remember, just if something comes to your mind, we will get to it at the end. We're going to move now to Cameron McNamee, who currently serves as the Director of Policy and Communications for the State of Ohio Board of Pharmacy. In this role, Cameron is responsible for the development and implementation of strategies to advance the board's legislative initiatives and other interests relating to the General Assembly. Prior to joining the board, Cameron served as a policy specialist for the Violence and Injury Prevention Program at the Ohio Department of Health. Cameron received a Bachelor of Arts in Government and Master of Public Policy from Georgetown University in Washington, D.C. So with that, we are going to turn it over to Cameron. Cameron?
I am not seeing Cameron on here any longer. I apologize. Cameron, can you hear us and speak?
I think, let me see, is Dana, are you available at this point?
Sure, I can.
Okay, is that fine? We'll see if we can get Cameron back on the line, and we'll move forward with Dana Quisenberry, who was so kind as to help me with her pronunciation of her last name earlier today. She is the program manager for the Kentucky Drug Overdose Program, funded by an award in the Prevention for States program at the Centers for Disease Control and Prevention to the Kentucky Injury Prevention and Research Center at the University of Kentucky. As the bona fide agent for the Kentucky Department of Health, her current work includes overdose policy evaluation. She has worked in community-based substance abuse prevention with the Rowan County Unite Coalition, a prior drug-free community support program grantee. Dana received her Juris Doctorate from Chase College of Law at Northern Kentucky University. She is currently pursuing her doctorate in public health, focusing on public health management and policy from the University of Kentucky. So thank you, Dana. We'll turn it over to you now.
Well, thank you. First of all, I'd like to thank all of you for allowing me to participate in the webinar today. And you were to have heard from Van Ingram, our Executive Director of the Kentucky Drug Control Policy. But unfortunately, he wasn't able to join us today in preparation for our upcoming legislative session. He has been pulled into some policy discussions that required his attention. So I wanted to thank him for his trust in, first for his slides, and then his trust and confidence in me that I can present his information today. Looking at Kentucky's policy response to the opioid crisis, I would like to start with this quote from the CDC, that essentially 1 out of every 550 patients started on an opioid therapy program died as a result of their opioid therapy program, usually within 2.6 years of the first prescription, which is a very short timeline. This became crucial in the discussions for what to do policy-related in Kentucky in 2010, when the number of drug overdose fatalities exceeded the number of motor vehicle crashes, which had been our #1 cause of injury death up until 2010. And most of this was based on prescription opioid abuse. A partnership with the Kentucky Office of Drug Control Policy, the Kentucky Injury Prevention Research Center, the Kentucky Department of Public Health, our PDMP, as well as a number of other participants, really started looking at this as a focus area under our core violence and injury and prevention program shortly after 2010. And what this resulted in was an omnibus bill in 2012, a special session called House Bill 1. And there's been quite a few presentations through the years on House Bill 1 in Kentucky. But I want to go very quickly through a couple of things that related to that and show how this policy success then has led to other policy interventions. The House Bill strategies really focused on 5 areas: prescription monitoring through our prescription drug monitoring program, prescribing regulations, drug pain clinics, drug disposal, and then prescriber and public education. Under the prescription monitoring program, our PDMP at that time was several years old, well established, had certain limitations, but one of the key pieces there in improving the use of the PDMP was making prescribers have mandatory accounts. We also improved reporting by pharmacies to within a 24-hour period. Also addressing the prescribers within the House Bill 1, the authority was given to the licensure boards to pass prescribing guidelines for Schedule 2 and Schedule 3 products with hydrocodone in it, both on the initial prescribing and then periodically if it's being prescribed for more than 90 days. It also invested additional requirements of our licensure boards to investigate complaints for prescribing irregularities to a 120-day timeline. Of course, it also limited dispensing directly from provider offices to simply a 48-hour supply. One of the biggest aspects of House Bill 1 that had an immediate impact was to address the pain clinics. And we've had 2 measures under the House Bill 1 that directly affected that. One is the requirement that they all be licensed as a pain clinic, and the second that they be physician-owned or hospital-owned. That required a greater level of supervision, and then essentially the owner had their licensure at risk for any prescribing irregularities. The drug disposal program was to encourage and do some authorization through legislation, make some legislative changes for the take-back of unused medications in the communities. And then we also focused on prescriber and public education and mandated prescribers to have 4 hours of substance abuse and addiction training every year. And what we saw is that immediately this had an impact. If you'll look at this, our July, essentially one fiscal year of dispensing for all of those substances, we saw immediately some decreases. One outstanding thing there is tramadol went up as we believe prescribers were looking for alternatives to hydrocodone and oxycodone. However, that resulted in some scheduling changes for tramadol that then were mirrored on a national level. The unintended consequence, however, of addressing prescription opioid access was the possibility that we've increased the demand for heroin. And this happened to fall in line with the same time in which the availability through Mexican trafficking through the Midwest and eastern states increased availability in our area. So how did we get here? The access and availability of heroin wasn't the only reason that increased heroin use in Kentucky. We have a long history of opioid and painkiller abuse, or intravenous drug use in certain parts of our state. The abuse deterrent formulations, or the lack of them initially, and then we're quite ingenious as culture, and we learned how to get around some of the deterrents that were put in place. Of course, the pain clinics, once they were closed, it created a vacuum in which patients who had been on long-term opioid therapy then had less access, or potentially less access to the medications they had been using. Of course, greater awareness from prescribers that also potentially limited access. Of course, then the opportunistic drug cartels recognizing that there was a demand that wasn't being met. So how do we want to impact the problem? We had already building on the success that our collaborative efforts around the formulation of House Bill 1 and the pieces that went into House Bill 1. We knew we needed to continue to work on public education, address access to treatment, enhance penalties for traffickers, and not just the low-level traffickers, but major traffickers, and also grant greater access to naloxone. So this gave rise to Senate Bill 192 in the legislative session of 2015. And it had a number of pieces. One of them is a public health surveillance piece that required our coroners to notify the county attorney when there was an overdose death that involved Schedule I drugs. We also included this Good Samaritan provision. Now, this was a hotly debated provision, and it wasn't until it went to consensus conference these pieces were nailed down. As you imagine, it created quite a bit of tension between law enforcement and prosecutors, as well as families. The family position being that it's our loved ones that are dying. They're not dying necessarily alone, or they're not using alone, but they get in crisis and they're essentially dying then alone. And we did have a number of very public instances where people were dropped off at the door of the emergency room and left by their friends and still did not survive. So the Good Samaritan provision had a strong community support piece through families and of people who have lost individuals to addiction, and that pretty much overrode the prosecutor and law enforcement concern. Also, the provision of naloxone. We've actually done quite a bit of work around this area. Initially, some pilot programs of having a drug overdose survivor leave the emergency department with naloxone in hand. A number of those programs have proved quite successful. We've been doing quite a bit of training of our law enforcement officers to be carriers and ministers of naloxone. And actually, one of the most interesting things that we're seeing in Kentucky, that our largest category of prescribers for naloxone has now become our pharmacists, because in Senate Bill 192, we actually included provision that with a standing order and a dispensing protocol, that pharmacists could both write the prescription and dispense naloxone, not only to patients being prescribed opioids, but also to others. And that, actually, I want to go back to that for just a second. When we start looking at policy language, initial conversations around this included, the original draft of the bill included language about being prescribed to patients. And in order to essentially, for lack of a better word, reframe the issue, that patient language was substituted with persons and other agencies to expand the vision of how naloxone would be distributed to beyond just the individual that was currently using opioids. When we look at the needle exchange option, that is also included in Senate Bill 192. It's a really uniquely crafted piece of legislation, this particular provision. It was helped along in part because at the time of the discussions in the legislative session passed Senate Bill 192 was also the time that Scott County, Indiana's instances of HIV exploded onto the national media. So that gave extra push for a needle exchange option. Unfortunately, our legislators were not willing to just pass a broad authorization on a statewide basis. Kentucky is a very strong home rule state, and so they wanted to include a local option. So now, in order for a community to have a needle exchange, the local health department has to initiate it. It then has to be approved by both the city and county governments in which the program will operate. We now have 14 active syringe exchange programs. There are a number that will be operational by mid-year next year. And the biggest challenge now at this point is not the politics of it, but the funding of the programs. Another very interesting way this conversation around needle exchange programs was framed was the hazard to individuals that are providing care, whether that be police officers, firefighters, EMS, even to the children in the community, and they come upon a dirty needle that's not properly disposed. And that really helped build support for the program. And the other piece that's very important in this, and it centers around this needle exchange program, is finding very strong legislative champions. And we were very fortunate with Senate Bill 192 to have two strong legislative champions, Senator Westerfield, who's currently remains in the Senate, and then Senator John Tilley, who's now the Secretary for our Justice Cabinet. They were both very strong advocates for the legislation and helped frame not only the patients versus the persons and other agencies, but also this concern around the workplace hazard for individuals that are responding to overdose. So the Senate bill was passed and signed by Governor right at the time that then Governor Mike Pence declared that the public health emergency in Scott County, Indiana. Also part of House Bill 192 is some treatment provisions. I won't go through these with great detail. However, they included looking at Medicaid and managed care, approval of substance abuse treatment providers. There had been a substantial delay, and it shortened the time that they had to approve those, requiring Medicaid to report out substance abuse treatment service utilization, as well as a piece of making EDs more responsive to treatment referrals to individuals who survived overdose in their EDs. We also designated a priority for pregnant women. Like many other states, we have seen an explosion of mass cases, and to address this, we gave priority funding for facilities that were going to treat pregnant women. We also funded Department of Corrections to look at using extended release opioid antagonists upon being released from custody. Of course, the downside of this, and part of the mechanizations of passing such a wide sweeping piece of legislation, is we also had to look at creating tougher penalties, and there was quite a bit of discussion at where that break for trafficking, how much should be subject to greater penalty, and this is where we ended up falling on the scale of increasing penalties. We also created a new offense of importing heroin into the state as being a separate charge. It's the first time that we've had something that really looked at the interstate transportation of or trafficking of substances into the state. Of course, the very nice piece of Senate Bill 192 is that for the first time we actually put money behind the legislation. So $10 million initially funded in 2015. Funding increased for another additional $15.7 million and $16.3 million in 2017. Of course, much of that is earmarked to some of the programs that we discussed earlier. One of the things that we do have, which is very nice, is that we're additional funding going into our community mental health centers with a particular focus on increasing access to medication-assisted treatment through the community mental health centers, and that was fairly revolutionary in the fact that there had been quite a bit of resistance for providing that level of care through the community mental health centers. We've also looked at some other judicial responses, including creating rocket dockets, placing social workers in public defender programs so that there's more hands on deck in order to get people connected and connected more quickly to treatment. So where do we stand now? In 2015, we had over 12,900, almost 1,300 overdose deaths. Almost a third of them had heroin in their final toxicology report. And as we're starting to address heroin, we have the increase in presence of fentanyl in our drug overdose cases. Overwhelmingly, most of our overdose cases are not a single drug. They are polysubstance related deaths. Due to our ability now through our drug overdose fatality surveillance system, we've been able to look at a number of data sets, including the death certificates, the ME's autopsy report, toxicology reports, reports from our coroners, and link them then with our PDMP data, and have come out with some great information about, at least for those overdose deaths, how many of them had an opioid prescription 6 months prior to their death. Well over half of them did. A third had an active opioid prescription at the time of their death, and basically 1 out of 5 had an overlapping opioid or benzo prescription at the time of their death. So we still have some work to do on addressing the prescription opioid problem, although also correlating to all of this, and it's not appearing on this slide, is the fact that we have seen reductions in our prescription overdose deaths. So what's next? We are not alone in seeing the increase of fentanyl appearing in our overdose deaths. We also have some issues around gabapentin being present. It's not necessarily responsible for the death, but it's been present in a considerable number of our overdose deaths. And that is, the cabinet is looking at making an emergency regulation for gabapentin to become a prescription or a scheduled for drug instead of just prescription only. And then just yesterday, our governor, by emergency declaration, scheduled U-47700, and we have been seeing that occur in a number of deaths. So we're looking at a variety of policy issues around these things. And I attribute our desire and our willingness to look at these policy interventions because of the success we've had in previous policy interventions, starting with House Bill 1 in 2012. This is Director Ingram's contact information. These are his slides. He can provide some additional information about any one of them, and this is my contact information. So I will take questions at the conclusion of the presentation.
All right, great. Thank you so much, Dana. That was fantastic. So Cameron, are you on now?
I am here, yes.
Hey, Cameron.
Sorry about that.
So it's okay. We already have heard Cameron's bio, but just as a reminder, he's the Director of Policy and Communications for the State of Ohio Board of Pharmacy, and very busy. So as you can see, folks who are working on policy have a lot of moving balls in the air. So we appreciate everyone's flexibility, and we will turn it over to Cameron.
Sure. Thanks, everybody. Yes, I apologize. I was actually in committee. I got pulled into a committee for a bill that we're pushing forward in Ohio related to prescription drug abuse, which I'll talk briefly about some of the items in there. But I am the Director of Policy and Communications for the State of Ohio Board of Pharmacy. And so the two policies I wanted to highlight and discuss are the state's mandatory use, mandatory PDMP use policy, a prescription drug monitoring program, as well as our efforts to expand access to naloxone. I'll start with mandatory PDMP use. Recommendation 2.1 from the Johns Hopkins recent Johns Hopkins report about evidence-based approach highlights the need for mandatory PDMP use by prescribers. Part of that has already been achieved in Ohio for prescribers. I'll talk about House Bill 341, which was enacted in April of 2015, as well as efforts the board has done to improve utilization by the pharmacist of our PDMP. So just a little about the landscape of drug overdose death statistics in Ohio. We had well over 3,000 Ohioans died of an unintentional drug overdose in 2015. About almost 22% involved a prescription opioid and 16% involved in benzodiazepine. We've done some matching between our overdose death data and our ORS data, which is our prescription drug monitoring program, and found that almost about a little over 74% had a record of receiving a prescription controlled substance. So we still see that very important linkage from prescription opioids to heroin to even the illicit fentanyl that we're seeing here in Ohio. So the Ohio Automated RX Reporting System is our prescription drug monitoring program. It's called ORS. We collect information from pharmacies, store it in a secure database, and produce patient-specific reports for healthcare professionals and law enforcement officers. 49 states, DC, and Guam have a PMP or a PDMP. It's kind of an interchangeable term, and Missouri is the only state without a PMP. So for ORS, we've actually just celebrated our 10-year anniversary. We currently collect about 25 million Schedule 2 through 5 controlled substance transactions each year. I'm sorry, that should say December 2016. So we're actually going to begin collecting gabapentin, as Dana from Kentucky recently just said, where we haven't made it a controlled substance, but we have made it a reportable drug, which we can do through administrative rule. So pharmacies and prescribers who are doing any dispensing from their offices will have to start reporting gabapentin in December of 2016. Like I said, all pharmacies and prescribers who personally furnish controlled substances, and personally furnish is just a fancy way of physician dispensing, have to submit data to us within 24 hours. The only entities that are exempt from reporting to us are veterinarians, and the VA facilities in Ohio report outpatient prescriptions to ORS within 24 hours as well. So a little bit about why ORS. ORS has a couple of components. One is it's obviously designed to monitor suspected abuse or diversion. But on the other hand, in our very fragmented system of healthcare, it does provide a critical information regarding a patient's controlled substance prescription history to the pharmacist or the prescriber. And this information, we feel, can help the prescribers and pharmacists identify such high-risk patients who would benefit from early interventions. This is a slide that I often use. This is where we were before we had ORS. So this is the top 10 doctor shoppers in 2006. So that's visiting. So patient A actually visited 105 prescribers and 50 pharmacies in a single year. So this is the kind of information that wasn't available to prescribers and pharmacists prior to the implementation of a PDMP, which we feel is of critical importance. So getting on to the PDMP mandates, our legislature has taken this very seriously. Our governor has been taking this very seriously since he's been in office, and starting in 2011. But in 2013, a summer study committee was formed, the Prescription Drug Addiction and Healthcare Reform Study Committee, and of members who are very, very interested in prescription drug abuse. And obviously that led to a very heightened interest in ORS. So as part of the study committee, the board provided testimony as well as sort of live demos of ORS to the study committee. There were hearings all over the state. We presented at one, which caught the attention of a lot of the legislators on the panel. Some of the testimony we did highlighted the underutilization of the system. So this chart you'll see is the number of ORS, of the number of prescriptions written in 2013. You can see we broke it down by 1 to 15, 16, 100 prescriptions, 101 to 500 controlled substance prescriptions, and 500 and more prescriptions. So you'll see 24% of Ohio prescribers really accounted for about 81% of all controlled substances written in the state. But unfortunately, for those high-volume prescribers, only 74% of them had an ORS account, which resonated very much with the committee. Understanding that having an ORS account or having a PDMP account is one avenue or one metric to use, but we also looked at utilization of said accounts. And so by looking at our 2013 data, we found that 16% of prescribers, including their delegates with accounts who wrote for more than 500 controlled substance prescriptions, never logged into ORS. So these are people that had accounts but just never used them, but these were high-volume controlled substance prescribers. Additionally, 57% of the prescribers who wrote for more than 500 controlled substance prescriptions hadn't accessed the system in the past year. So there was clearly a need to address the underutilization of the system. So the initial bill that resulted from the study committee, House Bill 341, began with mandating the use of ORS prior to prescribing any Schedule II controlled substances. This faced a lot of opposition from many of the prescriber groups around the state. particularly because Schedule II controlled substances also included, at that time it did not include hydrocodone, but it also didn't include, it also included stimulants such as Ritalin, Adderall, that were prescribed in high volumes but weren't necessarily contributing to overdose deaths as it resulted from the data from the health department. So what we did was the board, in consultation with the sponsor of the bill, Representative Ryan Smith, we worked closely and looked at, obviously the ideal would be checks for all prior to all controlled substance prescribing. These are addictive drugs for a reason. But what we ended up doing was sort of a compromise approach based on the data that we had available. So we reviewed the data from the Ohio Department of Health and determined the drug classes that were showing up in individuals' bloodstreams from the overdose death data. The other thing that we had to do was to get some of the prescriber groups to move from opposition to neutral to support was include a few exemptions, and I'll talk about those in a second. So what ended up happening was the passage of House Bill 341, which went into effect April 1, 2015. It required a review of the OR's data or the PDMP when initially prescribing or personally furnishing an opioid or benzodiazepine. So those were the two drug classes, obviously, that were contributing, prescription drug classes that were contributing to overdose deaths in the state. So that actually removed any opposition from mainly pediatrician groups that were certainly prescribing a lot of stimulants. The second was, then I talk about the exceptions. Less than a 7-day supply, that actually helped to remove some of the dental community opposition to it, because essentially they shouldn't be prescribing more than a 7-day supply of an opioid or of an opioid, I should say, for a procedure. Hospice cancer and end-of-life care was also removed as a reason to check ORs, and then immediately following surgery or other invasive procedure. It should be noted that this actually only applied to surgeons. So one of the complications was that some surgeons had PAs or nurse practitioners managing their patients, and if they were conducting the prescribing for those postoperative patients, it applied to them. Now, if the surgeon was writing, then it wouldn't apply to for them to check ORs. It also required mandatory registration upon renewal for practicing pharmacists and prescribers to prescribe opioids or benzos. And so this is important because everybody that renews their license is required to attest that if they are prescribers of said substances, they do have to have an ORS account. The other interesting part of this mandatory use was that if you are prescribing to an individual where their treatment is consisting of more than a 90-day supply of anything, so this tended to get at the chronic pain users, you had to query the system no more than 90 days after the initial request was made and every 90 days following. And so this didn't require patients to come back and get reassessed every 90 days. However, it did require them to be reviewed in the system every 90 days for prescribers who are treating chronic pain patients to monitor those patients to determine if there's any aberrant behavior as indicated by the report. Finally, the law also allowed the ORS report to be included in the patient's medical record. There hadn't been very clear guidance about, because there are some statutory prohibitions about disseminating ORS information, but a lot of which also included if it was in the medical record, but we made it clear for the prescribers that it could go in the patient's medical record. So pharmacists were actually, the legislation passed, once we had gotten all of those, kind of made some of those concessions, the legislation moved rather quickly through the legislature. However, it was pretty silent on pharmacist requirements. The board had some very obvious requirements for checking ORs. It really focused on if the patient is showing up, showing signs of abuse or diversion or appears intoxicated. Those kind of very simple, common sense red flags were requirements for checking ORs. However, the board did recognize the importance of the pharmacist in addressing prescription opioid abuse as well as other controlled substances, and really leveraged the passage of 341 as the opportunity to also put additional requirements on pharmacists. So in 2015, we started a review of what is called our prospective drug utilization review, or DUR rule. The DUR rule is where we hold the pharmacist accountable in what's known as corresponding responsibility. So federal law requires a pharmacist, 50% of that requirement for producing a legitimate script falls to the prescriber. The other half falls to the pharmacist. So there's sort of that equal share of the responsibility to ensure that a patient is getting a legitimate prescription. So the OAC new rule, which went into effect 2/1/2016, states the following. It says, prior to dispensing an outpatient prescription for a reported drug, the pharmacist shall request and review an ORS report, including a board or state's prescription monitoring program when the pharmacist is practicing in a pharmacy in a county bordering another state for a 1-year period of time. I should say that this border check requirement is also in House Bill 341, so that's where we took the language from. So these are the requirements. A patient adds a different or new reported drug to their therapy that was not previously included. This was a big one. So this is essentially says that any patient that comes in and says that they need to essentially, so they come in with an opioid script and then they move on and they come in the next day with a benzo script, ORS checks have to be run. So this led to a significant increase in the amount of ORS requests we saw from the pharmacist community. And then some of the other ones, ORS hasn't been run in a 12-month as indicated in a patient profile. A prescriber is outside the pharmacy's usual geographic area. Patients outside the pharmacist's usual geographic area if they're getting prescriptions from prescribers, from more than one prescriber, and the patient is exhibiting signs of potential abuse or diversion. So I just want to quickly talk about implementation. The board made, understanding that while we controlled the PDMP, the other licensing boards were responsible for implementing the law. However, we felt like there was still very much a knowledge gap with the prescriber boards that were responsible for enforcing this. So the board took it upon itself to really step up. We developed a comprehensive FAQ document that we helped disseminate and push out through the professional licensing boards. We made updates to the ORS website with new educational resources, including video tutorials. We made enhanced features, understanding we would see a spike in online registration. In registration, we included an online registration feature and password resets, as well as the development of quick reference materials. For the pharmacist, same thing, free online continuing education, educational materials for pharmacists, and I'll show them in a second, as well as additional education materials for pharmacists about essentially how to say no. So this is our pocket card that we developed. One side's pharmacists, other side is prescribers, gives them kind of a real quick overview of the rules. And then here is our campaign about it's okay to say no. This helps. What we found is pharmacists sometimes have difficulty having difficult conversations with patients, and so we created a sort of a sheet that they could refer to in regards to having that difficult conversation with patients, has treatment resources available to it for them. And so that helped facilitate that difficult conversation. So here's just you'll see the difference between the Q1 and Q3 overall request statistics from prescribers. We've seen increasing trends in terms of prescriber usage of the system as well as pharmacist usage of the system. However, we are doing now monthly referrals over to the boards, and they are sending out some letters to these prescribers, which has triggered, certainly you'll see here we had a fair amount of physicians and APRNs missing a fair amount of patients that would fall under the requirements of the law. So we are having an enforcement piece associated with this as well. And then lastly, I'll just quickly talk about evaluation. We're working with the health department to evaluate the actual law itself, House Bill 341. And part of that will look at an analysis of the exemptions and whether those should exist, continue, or should end. And then we're planning to conduct additional analysis and evaluation of the pharmacist mandates in 2017. And then finally, I just wanted to, we did all this sort of with the stick, saying thou shalt, but the state also recognized that integration is essential and is key and sort of the next step for improving access to ORs and PDMPs. So the state's investing about $1.5 million per year to essentially cover all the costs associated with integrating ORs directly into electronic medical records and pharmacy dispensing systems across Ohio. We had a great Kroger study pilot here where we essentially, the Kroger pharmacy chain conducted integration, and as a result of integration, well over 100% of prescriptions for controlled substances were checked at Kroger pharmacies. So I'm sorry, I thought I had more time. My slides for about naloxone, we'll talk all about how we're expanding access in the pharmacies, but I will turn it back over to our moderators. Thank you so much.
Oh, thank you, Cameron, so much. We have had such a great amount of information presented, and we always don't have as much time as we hope we would have. But we did want to get to just a few of the questions that have been put out since we started talking all the way back to Corey. So the first question we have is from Lori Clary, and she's asking, if someone is in pain, would it be helpful to focus on accurately diagnosing the cause of pain and ensuring the patient has access to treatment for the health problem that's causing the pain? Therefore, we'd eliminate the need for opioids. Are there any efforts at working upstream in this way? I don't know if
I don't know. This is Dana. I'll take an attempt at answering that. I think that's a great idea, and it's probably where things like the CDC prescribing guidelines, the individual state prescribing guidelines, it's probably the direction they need to examine ongoing, is that there needs to be a set diagnosis. Now, our prescribing guidelines include something to that nature, but there really isn't an enforcement mechanism for that, and so I'm not sure how much that's being utilized.
Okay, does Corey or Cameron, did you want to weigh in on that?
No, this is Corey. I mean, I'll just say, yeah, I mean, clearly that is, the idea behind that is absolutely correct. And there's a lot going on there, right? I mean, you have people who are uninsured, underinsured. You have clinicians who are pressured to spend very little time with patients, really an insufficient amount of time to really get at what is the core problem. You have increasing specialization among physicians, so that they may not actually have the knowledge necessary to properly diagnose the person. So there's a lot going on there. Unfortunately, I'm not aware of any really great interventions to try to address that. I mean, besides this general idea that, don't think of, reaching for the prescription pad and prescribing an opioid as, your first reaction to someone who presents with pain. I think that that's an important part of sort of addressing inappropriate prescribing, but it really, the questioner is asking, what are we doing upstream from that? What are we doing to get this person the care that they actually need? And I would love to hear anyone who has examples of places that are doing that well. Unfortunately, I don't know of any.
Okay, that's good. That's good to kind of hear that kind of novel idea. And in the chat box, if anyone does have any information, we'd love it if you could share. But I think with that, we will move on to a question from Mitch Cunningham. And this is in relation to PDMP and the limited use of the data by HIPAA. But he's asking, shouldn't HIPAA allow for a more proactive use of the data?
This is Cameron with Ohio. I guess I'm wondering what, in terms of proactive use, what is the concern? We do proactively use the data. Not only to do enforcement actions, but also we do proactively provide that data back to the prescribers so they're aware of we have like an insight report that is proactively sent out to prescribers on a regular basis, kind of their reverse ORS report they call it in Kentucky. So I guess I'm just wondering what the HIPAA concerns are as it relates to PDMPs.
Yeah, this is Corey. I would just echo that. I mean, in general, HIPAA is not a barrier to use of PDMP data to target interventions and that sort of thing. I mean, I'd be happy to talk to the questioner offline if they have a specific question or concern.
Okay. I would echo what Corey said, that from the standpoint, each PDMP has different mandates in their authorizing legislation. In Kentucky, we are not allowed to do any proactive reporting. And it wasn't until 2012 in which we could do any public health surveillance out of our PDMP. So I would encourage the questioner to look at the authorizing statute for their PDMP to see what the limitations are.
Gotcha. The next question is around naloxone use, and some research was cited in the question about possibly increases in opioid use because of access to naloxone, and wanted to see if you all had any comments on that concept.
This is Corey again. I hate to monopolize this. I didn't see I can't actually see the question. To my knowledge, there is no actual prospective evidence that access to naloxone increases opioid use or risky opioid-based, opioid behavior. There is research out there, including some, recently published research where you ask people, if we gave you naloxone, would this change the way you use drugs? And some percentage of people say, yeah, I think I would use more drugs, or I think I would use drugs in riskier behavior. But the studies who have looked at what actually happens find no evidence that that actually happens. That, you're asking people, if we gave this to you, would your behavior change? Some percentage of people say yes, it would. But when you look to see if it actually did, it doesn't, as far as I know.
Right, that's my understanding too, and I think when we look at what happens when you have to have a dose of naloxone, it's not pleasant. So, yeah. Does anyone else want to weigh in on that one? Okay.
I mean, I would say, this is Cameron from Ohio. I hear that a lot. But yeah, I haven't seen necessarily much data that says that does point to that issue. I think for us, it's just a matter of keeping the person. Overdose is a teachable moment, so you want the person to be alive long enough to to change their behavior and to have access to treatment, and particularly when the demand for treatment is soaring as a result of this epidemic, we can't just leave people who are on the waiting list high and dry in terms of wanting to get help but can't get into a facility yet. So I see it as sort of a bridge to helping them to get to recovery, but they can't recover if they've passed away. So.
Right. That makes perfect sense. So unfortunately, we have just 1 minute left. We had a few other questions, but one I just wanted to cover from a few people is that, yes, the slides and presentation will be available on the link I just posted in the chat box. Further, the application to apply for this project going forward is also going to be available on this website. Explains the deadlines, it explains the purpose of what we're trying to do, and we really hope that we will see some applications from folks in the near future. I wanted to say a big thanks to Safe States for their great hosting and helping us out with this webinar, and to UNC Injury Prevention Research Center for making the larger IPOP project possible, and of course our fantastic presenters, Cameron and Corey, and for Dana for stepping up on very short notice to cover Van's presentation. And of course all of our listeners for coming in this afternoon and contributing and listening, and hopefully wanting to take some of this information back out into their work and make some positive changes out in their community. So with that, I will sign off, and I thanks everyone again. Have a great afternoon.